Okay, so I think we can slowly start. Again, welcome everyone. So I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, so the European Reference Network on Rare Hematological Disease. And I'm really happy and glad to welcome all of you to this seventh webinar of a cycle that is part of the ERN-EuroBloodNet topic on focus on constitutional thrombocytopenia, that, as you may know, is an accredited European online educational program that targets health professionals and is organized by the ERN in partnership with the French Reference Center for Inherited Platelet Disorders and the Filière MHEMO, the French Constitutional Bleeding Disorder Network. And indeed, I had the pleasure to co-organize this program with 3K experts, so the Professor Marie-Christine Alessi, le Dr. Paul Saultier, both from the EPHP in Marseille, in France, and Dr. Mathieu Fiore from the CHU Bordeaux. So as you know, with this program, we disseminate up-to-date knowledge among health professionals in the field of constitutional thrombocytopenia. The program consists of 15 webinars tackling really from A to Z this disease domain. And before entering to today's lecture and presenting to you the speaker, I would like to share with you some information and home rules. So first of all, this program is accredited with continuous medical educational point issued from the European Body of Accreditation in Hematology. For requesting credits, it's very easy. We are going to contact you, providing you the instruction to request formally the credits. We have the tracking of your presence. So just one request is that at the end of the webinar, you are going to receive a short survey, but it's important to answer because it's part of the criteria for getting the credit. It's 3 easy, quick question on satisfaction. Then continuing with the rules, as you can see, this program is recorded because all the videos will be nourishing the e-learning environment of the ERN. So if you don't feel comfortable, feel free to switch off your camera, change your name in the platform, or simply notifying it to me, and we will take care of it. And then your microphone will be muted along all the presentation, but at the end, we will have the possibility to address your comment, feedback, questions, because we will have a Q&A session. So feel free to write your question in the chat during the presentation, or you can also raise your hand and I will pass the floor to you at the end of the presentation if you prefer to express orally your comment or questions. So today we are going to talk about Wiskott-Aldrich syndrome and X-linked thrombocytopenia. The lecture will be provided by Dr. Coralie Mallebranche. She works at the CHU Bordeaux in France since 2017 as a pediatrician in the oncology, hematology, and immunology unit. She focuses particularly on the diagnosis and treatment of non-malignant hematological diseases and primary immunodeficiencies. And she has also clinical and basic research work on X-linked thrombocytopenia and the pathophysiology of associated complications. So I'm really pleased and honored to pass the floor to Dr. Coralie Mallebranche. The floor is yours. Thank you.
Thank you for this nice presentation. So I will try to share my screen. Okay. I think it works. Is it okay for you?
Yes, perfectly. Thank you.
So thank you very much for inviting me today. And as Marie-Angela said, I used to follow a lot of patients with X-linked thrombopenia in my clinical activity. And a part of my research activity is about this disease. So I'm really glad to present you my point of view on this disease today. Okay. So in the first part, I will focus on the gene and the protein, and after we'll move on the clinical and the treatment of the Wiskott-Aldrich syndrome. So the Wiskott-Aldrich protein is encoded by the WAS gene called after the Wiskott-Aldrich syndrome because of it was discovered after. And this gene is located on the chromosome X, XP11, and the gene is composed by 12 exons. The protein is composed of several domains, and these domains allows the bind of the protein with a lot of another protein very important for the activity of WAS protein, notably in the regulation of the actin network in the cell. The WAS gene is mainly expressed in hematopoietic cells, and its expression is very high in the whole blood. And as we can see, there is an expression in the spleen, the intestine, and the lung, because they are rich in immune cells too, but the main expression is in the whole blood. WASP for Wiskott-Aldrich syndrome protein has two main types of function. The first function is part of the actin cytoskeleton independent function, and it's more as a direct action of the protein in the T-cell differentiation, for example, or activation of B cells, transcription of cytokines, regulation of myeloid cells. But we'll mainly focus on the actin cytoskeleton dependent action, because it's this action that is really important in the pathophysiology of Wiskott-Aldrich syndrome. The Wiskott-Aldrich syndrome protein acts as a scaffold protein that mediates dynamic changes in the actin cytoskeleton. The protein has two states, auto-inhibited one and active one, and during the engagement of the TCR, the protein has a lot of changes. So in the auto-inhibited state, the GBD and the VCA domain are very close. And when the TCR is engaged, the CDC42 bind to the GBD, and there is a phosphorylation of a tyrosine located on the GBD domain. And both of these action allow the opening of the RAS protein and allow the fixation of the binding, of the VCA domain with ARP23 protein. And this ARP23 protein has a fundamental role in the induction of a new branch of actin. So it's the very beginning of the formation of new actin branch, and it's essential in the formation and in the dynamics of all the actin cytoskeleton in the cell. The actin cytoskeleton dynamics is involved in many different activities in hematopoietic cells. To start in the lymphocyte, the cytoskeleton dynamics is essential for proliferation, signaling, and assembling of the immune synapse, the polarization and release of a lot of cytokines, and the migration of the lymphocyte. The functions are much the same in the phagocytic cells, but in these cells, the the cytoskeleton network is involved too in the adhesion of the cells and as a big part in the phagosome system, and we'll talk about that a bit later. To finish with this slide, the cytoskeleton has a major role in the formation of platelets from megakaryocyte, and it is described that the mutation in the WAS gene could lead to an early release of platelets into the bone marrow. These platelets are impaired with a smaller size due to the mutation, and the early releasing in the bone marrow could increase the destruction, the early destruction of the platelets in the bone marrow. So, as you can see quickly here, the cytoskeleton and the RAS protein is really important in all the hematopoietic system. Just a brief part about Wiskott-Aldrich syndrome and autoinflammation, since a lot of works in the last years are about this topic. Wiskott-Aldrich syndrome protein has a big role in the formation of a phagosome, so it's involved in autophagy. And a lot of recent work show that an impaired autophagy could lead, of course, to a defective bacterial clearance. And this defective bacterial clearance in the phagocytic cells could induce an excessive inflammasome activation and maybe be a part of the autoinflammatory manifestation that could be observed in the Wiskott-Aldrich syndrome. Besides this part, an impaired autophagy could impact to the mitophagy. Mitophagy is the regulation of the mitochondrial network in the cells, and is really important to maintain the integrity of the mitochondrial function. And an impaired mitophagy due to Wiskott-Aldrich syndrome protein mutation could lead to an alteration of mitochondrial respiration and maybe to a metabolic dysfunction in the frame of the Wiskott-Aldrich syndrome. So after this first brief part, come back to the disease with the story of the disease. So the first description of boys with inherited thrombocytopenia associated to eczema and recurrent ear infections was made in 1937. As in some other disease named after scientists who may be involved in the National Socialist Party in Germany during this period. The question is maybe to rename the syndrome after only Dr. Aldrich that described for the second time the disease with a X-linked thrombocytopenia in 1957. The first really description of the human deficiency associated to this thrombocytopenia was in 1960. And finally, the gene was discovered in 1994. And 1 year later, the link between X-linked thrombocytopenia and Wiskott-Aldrich syndrome as part of the same disease, secondary to mutations in the same gene, was described. The initial and main description of Wiskott-Aldrich syndrome is a clinical triad associating recurrent infections, eczema, and thrombocytopenia with small platelets. The diagnosis features are usually quite similar. At the time of diagnosis, the first sign is usually a thrombocytopenia with petechiae, bruising, bleeding, occurring in a boy and classically early in the life, during the first year of life. And one of the particular signs is the presence of small platelets. Sometimes eczema or recurrent infections or severe infection may be the first sign, but it's more rare, and more rarely again some autoimmunity or malignancy, but classically it occurs later in life. Just a quick glance at the genetic transmission. As I said, that the disease mainly affects boys. That's normal because WAS gene is located on the X chromosome. So in case of mother that carry mutated allele of WAS gene, one girl in one will be carrier and one boy in one will be sick. In case of a sick father, all the girl will be carrier, but the boy will be healthy. And in the particular case of a sick father and a carrier mother, the situation is more complex because one girl in one will be sick, one girl in one will be carrier, and one boy in one will be sick. I just wanted to talk about that because we have a lot of patients in this case in our local cohort due to a high degree of consanguineous unions, and that explains that we have a lot of sick girls in our cohort. The reference diagnostic method is genetic analysis. In February 2024, 612 mutations were described on this gene. So there is a huge amount of different mutations, and we can find all types of mutations. A third of these mutations are de novo mutation. The Western blot and flow cytometry can be used to assess the level of expression of the protein, and can be helpful in the evaluation of the severity of the disease. But some patients can show normal levels of protein, but with an impaired function of Wiskott-Aldrich syndrome. And sometimes the protein seems to be totally absent due to a disturbance of detection, even if there is few or part of active protein. So even if Western blot and flow cytometry can be really useful, the gold standard remain the genetic analysis that is really important to have to confirm the diagnosis. The thrombocytopenia is the main sign of the disease and is present in all patients from birth. The level varies between patient and varies during life, but classically the thrombocytopenia is profound and could be less below than 20 giga per liter. The distinctive feature is the presence of really small platelets, as we can observe on the C picture. In association of this low number and small size platelets, the platelets have this function. I'm sorry because it's not my favorite part, but I will try to be quick and accurate on that. The integrin dependent response could be defective in this patient because requiring a very strong interaction with cytoskeleton, and these platelets could have some functional impairment besides the issue due to the number. So as we can see, and to resume, there is a lot of different issue with the platelets in this disease. Usually the number of megakaryocyte is normal, but the platelet formation is abnormal with a low number probably an early destruction in the bone marrow, a dysfunction of platelets with little size, and dysfunction of activation, adhesion, spreading, clot retraction due to this integrin impairment. And in addition of all these issues, there is a part of autoimmunity on platelets that is adding to all these features. The thrombocytopenia could be maybe really severe and is a part of the death that are observed in this disease. There is two peculiar situation. The first one is the severe bleeding, in which case we have to search for an autoimmune platelets consumption, especially if it's a patient with usually very few or moderate symptoms that started to have a very severe bleeding. We have to be careful about autoimmunity. And the second one is the peculiar situation of infants with refractory thrombocytopenia very early in life, that lead us to consider definitive treatment very quickly in life. So besides this big part on platelets, but it was the topic of the day, the immune system is an important actor in Wiskott-Aldrich syndrome. As previously described in actin activities, lymphocyte and myeloid cells are dysfunctional, in part due to this impairment of the actin cytoskeleton network. In T lymphocyte, we mainly observed diminution of level of CD8 lymphocyte. Treg could be impaired too. And we can observe an alteration of the proliferation of the lymphocyte. B lymphocyte defect could be sometimes less important, and number of B cells could be normal. The hypo-IgG, the immunoglobulin G could be both normal or decreased. But even if the level of immunoglobulin G is normal, the response could be impaired, especially the polysaccharides response. And we classically observed an elevation of IgA and IgE level in this patient. And to conclude with this slide, dendritic cells and macrophages had defect too in migration, chemotaxis, and defects in antigen presentation that is involved in the global antigenic defect in these patients. So, of course, this immunodeficiency leads to a high risk of infections. Bacterial infections are often due to encapsulated bacteria. And this patient could present recurrent otitis, sinusitis, pulmonary infection, or more severe infection as meningitis and septicemia. And of course, this risk is increased in case of splenectomy in this patient. These patients are also susceptible to opportunistic infection, whether viral as a CMV infection, and that is really common in the patient, and fungal infections. The third part of the classical clinical trial is the eczema, and that could be more or less severe in the patient, and that resemble to classical atopic dermatitis. The autoimmunity is present in 40 to 72% of patients, according to the literature. The main part of the autoimmunity is composed by autoimmune cytopenias, including autoimmune hemolytic anemia. The patient could present to neutropenia and or ITP, and as you can imagine, the addition of an ITP, that is an autoimmunity on platelets, is severe concern in this patient that already have platelets impairment. The pathophysiology is less clear for other manifestations as vasculitis and renal disease that are usually described as a part of autoimmune manifestation in this patient, but I think that they are a bit different than the more classical autoimmunity. The renal disease has a rate variable between the studies, between 3 and 19%. I think it's more around 5% of the patient, and that is the number that we have in the French cohort. A lot of different pathologic findings were described, but the IgA nephropathy seems to be the more frequent. Hematuria is quite frequent too at diagnosis, and the hypotheses are unclear, maybe part of autoimmunity, but some aberrant glycosylation of IgA that is present at a high level in the blood could be involved in the renal disease. So unclear, but probably linked with the IgA pathophysiology that is impaired in this patient. As with nephropathy, the pathophysiology of vasculitis remains unclear. The vasculitis mainly affect the skin, hopefully, with a lot of leukocytoclastic vasculitis. Some cerebral vasculitis were reported and are usually severe in this patient. And the pathophysiology could be linked to with the high level of IgA and IgE, and maybe with the deposition of this immunoglobulin in the vessel wall, leading to the necrosis of the vessel. The aneurysm, as probably a part of this vasculitis part, are rare but can exist, and so we have to know that. The pathophysiology is probably the same, and some case reported aneurysm in the aorta, for example, that can be lethal in patients. Finally, the last classic complication for Wiskott-Aldrich syndrome patient is the onset of hematological malignancies, in particular non-Hodgkin lymphoma and leukemia. 5 to 10% of the patient could be concerned during life. And it's important to note that the prognosis of this patient is usually poorer than the prognostic of the same disease in patients with normal Wiskott-Aldrich syndrome protein. The big question is how to assess the severity of Wiskott-Aldrich syndrome, and with this question, my question is how to know which patient will be severe during life, and so which patient will need a definitive treatment. The main way to assess the severity is the use of a clinical score based on OX team works. This score gathered all the potential clinical features, And according to the number and the severity of the clinical features, the patients are sorted in 5 groups. The first and 2, the group 1 and group 2 are called X-linked thrombocytopenia patient, because usually they have no or very few other symptoms besides the thrombocytopenia. And after the patient had more and more symptoms until the group 5, that is the severe WAS phenotype. It is important to know that the onset of autoimmunity, vasculitis, or neoplasia is a cause of a grade 5 a classification for this patient. Usually the assessment is done at 2-year-old, and we consider that patients that have a score below 3 or 4 at 2 are patients with a mild form of the disease, so X-linked thrombocytopenia. But it's really important to keep in mind that even if these patients have a very low score at 2 years, the complication can occur through whole life in this patient, and we have to stay very careful about the onset of a complication in this patient. The level of WAS protein could be useful too to assess the severity besides the clinical severity. Patients without any expression of WAS protein usually have more severe infections, more eczema, more bleeding, and a higher risk of malignant tumors. Whereas patients with an expression of the protein, even if the expression is low or impaired, have a better survival, less bleeding, and few malignant tumor. The risk of autoimmunity looks like the same in both groups. But even if this expression could be helpful to assess the severity in this patient, everything is not predictable. For example, some patients have very early onset of life-threatening manifestations during life, especially in the first year of life. It was the work of Nizar Malawi in the French cohort. And without any explication, some children had a very, very early severe disease. The biggest part of this patient had a highly predictable mutation for the absence of WAS protein, but some of the patients hadn't a highly predictable mutation. So it's hard to predict which patient will really have a severe early disease. And on the other side, a patient with a disease that looks like quite mild in the first year of life could develop life-threatening manifestation all through her life. And we can see that even if the overall survival is not that bad in this patient, the event-free survival is low. And at 60-year-old, 75% of the patients will develop a severe infection, a severe bleeding, an autoimmunity, or a malignancy. So complications can occur through whole life, and that's really my key message today. And even if the patients are considered as mild patient, X-linked thrombocytopenia patient, we have to keep very careful about the onset of complication. And even if the patients are in a family with a lot of other patients, this is the family tree of the big family followed in my center. as I told you before, there is a lot of consanguineous unions in this family, explicating the loop. But we can see in black or color the sick patient, and some of them had severe recurrent infections, some of them have vasculitis, some of them had nephropathy, and we were totally unable to predict which patient in this huge family will have some complications. So it's really hard to predict something in this disease. To finish, and after this overview of the disease, the final question remains how to treat this patient. So we'll start with the supportive therapy and after move on definitive therapy. The prevention of the thrombocytopenia is essential in this patient, and the goal is to avoid high-risk situations and educate parents and patients about the signs that should lead to consultation. The big point of the thrombocytopenia is that the platelet transfusions are not systematic in this patient, even in case of a low level of platelets. And the transfusion are kept usually for emergency situation or before plain surgery if any other alternative is available. The platelet transfusion could indeed maybe increase the autoimmunity. The splenectomy is used in some team to care or to improve the thrombocytopenia. It's really controversial. For this presentation, I read a lot of papers about the reverse team. It's in London, I guess. And they agree to the benefits of the splenectomy for this patient. And as we can see in this plot, the splenectomy allow to increase the level of platelets because due to the autoimmunity for part, the destruction of platelets take part in the spleen. So the splenectomy could allow to increase the level of platelets, but there's no function on the dysfunction of the platelets. So the platelets remains dysfunctional, and it's the main part for me. The splenectomy, even if it works, increase the risk of infection that is high in this patient. So in my team, we avoid splenectomy in this patient due to this high risk of infection and due to the previous death of some patient after splenectomy. So as I told previously, the transfusion are mainly used in case of emergency and severe bleeding. We used it before plain surgery too, but before plain surgery, since few years, we try to use the L-thrombopag or other platelets agonist, and we have an effect on platelet level with elevation of platelet level, as in the splenectomy, that this way don't correct the dysfunction of the platelets, so we have to remain very careful even if the level is better. But it allows us to perform some surgery with less transfusion, so it's quite a good deal, I guess. And the platelet agonists weren't considered as a long-term basis treatment, and they are used for short period currently. About thrombocytopenia, finally, in the event of a sudden increase of cutaneous or mucosal hemorrhagic signs, an acute drop in the platelet count, a failure of platelet transfusion, we have to suspect an autoimmune consumption, so an autoimmune mechanism added to the previous platelet impairment. And in this case, the treatment is quite the same as in the ITP with steroids, IVIG, and in case of failure, rituximab. About the other complications as autoimmunity or malignancies, there are not really a very specific treatment, and the supportive care is usually the same as the treatment used for autoimmunity and malignancies in patients without Wiskott-Aldrich syndrome. But the important message is that if some autoimmunity or malignancy occurs in a Wiskott-Aldrich syndrome patient, we have to consider moving on a definitive therapy for this patient. Because in case of malignancy, the risk of relapse is really high. It's the same for autoimmunity, it's the same for the nephropathy, even after renal transplantation. So we will have to consider definitive therapy in this patient. The definitive therapy from me and according to literature is definitely indicates in all children with genetic mutation consistent with a classical WAS and no expression of Wiskott-Aldrich protein. In the severe WAS and early onset severe WAS, the definitive therapy could be considered as soon as possible. And it's the same for me for patients with hematological malignancy, severe autoimmunity, or nephropathy of vasculitis. The question is a bit harder for patients without very hard complication, but we know that the quality of life could be impaired in this patient. So the question remain ongoing for patients with impairment of the quality of life, because I think that it's a big part of the patient. And if the donor or the treatment is available, the question could be present to perform a definitive therapy in this patient, maybe in preemptive treatment. About the hematopoietic stem cell transplantation, it is now the most widely used definitive treatment in Wiskott-Aldrich syndrome. The overall survival was really good in the last studies, and the overall survival reached 100 in some recent studies, and it's the same in our cohort since 2010 without any deaths related to the transplantation. And this survival is really high regardless the type of donor of the type of graft. But we know that the transplantation presents complication. One of the big questions is the choice of the good age at transplant. We used to say younger is better, but this question could raise issue about the side effects of the conditioning regimen. So we know that it's better to perform transplantation before the arising of complication, but when, before 1 year, before 5 years, before complication, it's still unclear, even if some studies agrees that it's better to perform the transplantation before 5 years old. It's the same about conditioning regimens. The most part of the conditionment related in the studies are myeloablative conditionment, and we know that it's allowed to have a strong engraftment, better than in reduced intensity conditioning, but the disease correction is achievable with lower conditioning. So it's a big part of the studies on transplantation in this patient to know how to adapt the conditioning to try to reduce the long-term complication with improving the engraftment. Of course, acute and chronic GVHD is described in this patient, around 20%. The transplantation allows to resolve autoimmunity present before the transplantation, but the risk of de novo autoimmune disease is important in this patient, around 15%. And we know that in transplantation, long-term complications are important, and the two main question remains for me, at which age the transplantation should be performed and which conditioning choose in this patient. Finally, the gene therapy. The gene therapy is studied in worse disease since the early 2000s. And the current form is an antiviral vector expressing Wiskott-Aldrich syndrome protein. Out of 9 patients reported in the last 2 days, 1 death occurred. It was a patient with a pre-existing very severe viral infection, and the other patients are well now. The gene therapy allowed to reduce the secondary effect and to avoid GVHD. In Wiskott-Aldrich disease, the gene therapy allows to restore the count of lymphocytes, but and it's the main issue. The gene therapy is very less effective on platelet counts, with a level of platelets achieving a level above 100 giga per liter in only 3 patients in the 9 patients studied. So it's a big concern in a disease involving platelets. And the other issue is that the gene therapy doesn't allow yet to resolve all the pre-transplant autoimmunity, and that as in the transplantation, the de novo autoimmunity can occur in this patient. So in conclusion, and from my point of view, one of the greatest challenge, or my greatest challenge at least for the coming year, is to try to determine which patients are really at risk of complication, because it's quite clear that for patients with severe form of Wiskott-Aldrich syndrome, these patients have to receive definitive therapy. Okay, we have to improve gene therapy efficiency or to reduce allograft toxicity to be better with this definitive treatment. But the big question is how to choose patient considered as mild risk patient. How to choose which of these patients will benefit to the definitive therapy. For that, I think that it's really important to try to improve our understanding of pathophysiologic of complication. For example, to understand better how the vasculitis occur, how the autoimmunity occurs, which is the trigger of all this complication. And it will be allowed to detect maybe early which patients will benefit of a preemptive definitive treatment, and to be more effective in our choice for this patient. That's okay for me. Thank you very much again for inviting me today, and I'm available for your question. I hope it was clear and complete. So thank you.
Thank you very much, Dr. Mallebranche. I think it was very comprehensive and clear. So, as said before, now you can both raise your hand and then we'll unmute yourself, or you can write your question in the chat. If you want to ask, yes, I see first question arriving. Thank you for this presentation. Do you know if the impact of WASP mutation on its ability to bind CDC42 is taken into account in the score used to predict the severity of the disease?
Currently, the score is really clinic. We use the score called OX score with the clinical feature, and there isn't really comprehensive score with genetic clinical features. So we use quite a separate way the clinical and the biology, but it's I think that the ability to bind CDC42 is used in the evaluation of the potential severity of the mutation, but not in everyday basis now.
Thank you. I will pass to the second question. Which kind of surgeries did you perform in Wiskott-Aldrich syndrome patients with only electromobag bleeding risk? Since electromobag don't correct the platelet function impairment, did you perform a functional platelet test before allowing surgery after electromobag treatment? Thank you.
Of course, it's mainly little surgery has for sorry, I'm looking for the word for it will come before to put some catheter, for example, for patients. But when we need to perform some neurological or main profound surgery, we associate both electromobag and transfusion. And yeah, if the surgery is supposed to be severe or at high risk of bleeding, we use both together, but it's allow us to reduce the transfusion. And we never had issue with this patient, but yeah, it was with quite simple surgery and low risk of bleeding. And no, we never used to perform functional platelets test before. One of the issue is that usually in my center, to be honest, we don't have a basis functional test in this patient because they are already thrombocytopenic, and we don't perform this test, and that's the same even after electromobag treatment.
Thank you. So I move to the next question. What are the proposed explanations for the autoimmunity recurrence after transplantation?
The main explanation I saw was about Treg impairment. I saw that Frédéric Rieuleca is there, so I don't wanna tell some mistake about Treg. But yeah, it looks like it's an issue with the Treg and maybe Breg restitution after transplantation.
Great, thank you. So I move to the next one. Is the variable clinical severity could be correlated with somatic reversion in different subsets?
I didn't read anything about that, but maybe it's a lack of knowledge about me. But the variable clinical severity is linked with the kind of mutation, of course. But I don't know if some somatic reversion were described, probably, but I'm sorry, I don't read anything about that, so I can't really answer. But yeah, maybe because we know that, for example, in the HCT, a partial reconstitution of a partial chimerism could be sufficient to reverse some of the symptoms. So I think that, yeah, maybe somatic reversion in some cells or some subset could improve the severity.
Thank you. So I will take the last two questions. Thank you for this great talk. In your opinion, what are the more promising research efforts to identify the patient with XLT that will experience severe complications several years later?
So I will try to guess the future. For my point of view, I'm very interested about the research on the involvement of phagocytosis in the disease, because I think that it could be linked with some unclear mechanism as autoimmunity, and I think that a better understanding of this part very in the very internal cell involving mitochondrial network could be promising for a better understanding of the complication and maybe for some targeting treatment. I don't know, maybe.
Thank you. Given that you transplant patients fairly early, how do you select patients in absence of complication? What is the percentage of patients transplanted in your department?
In my center, we have a lot of patients, but these patients have a mild form, quite XLT form, and we didn't transplanted all these patients now. In the previous years, we used to transplant patients after the upcoming of complication, and that's why we try now to detect maybe earlier the patient. But as I said, we don't have a very good way now to detect which patient with a mild form will have complications. So currently, we propose transplantation in patient that looks more severe than usual when they are younger. For example, recently we transplanted two young girls with very early infections as meningitis and sepsis. So it's more like this. And we transplanted patients when they asked for it, if some donor is available, because for some of them, the quality of life is really impaired, so we take this into account. So I hope we'll be able to have more selective criteria in the coming years.
Thank you very much. So, Borello, you can unmute yourself because I've seen you request to raise your hand, but I will please ask to be quick as we have already run the time.
Okay.
Thank you.
Thank you. Thank you very much. Can you hear me all right?
Yes.
Yes.
Yeah.
I have a case actually I'd like to discuss. I'll try to be quick. It's exactly about the indication for transplant. It's a young boy. He's an 8-year-old boy with very low platelet counts. He stays around at 10, 15 per microliter with, with a moderate phenotype. He has recurrent nosebleeds. At least twice a year, we have been transfusing him with platelets for severe nosebleed requiring the placing of tampons in the nose. And we had even transfused him of red blood cells due to severe nosebleeds. And so quite the moderate phenotype, at least. And he has been refractory to TPO agonists, both romiplastim and L-trombopag. And he has a normal infection burden, but he already had 2 cases of herpes zoster infection. He has a very low count of CD8 T cell. He has absent immunoglobulin M and absent response to polysaccharidic antigens, but no eczema. So he has a moderately severe hematologic phenotype, absent clinical immunodeficiency phenotype, but with a laboratoristic immunodeficiency. And we were wondering what to offer this patient, because as you said, splenectomy would increase the risk of infection. Transplant, maybe, but we feel it's a bit over the top. And the family strongly believes in genetic therapy, but we already told them that for now, it would not be beneficial on the platelet count. So would you go forward and propose a transplant in this case? Only if there is a sibling, or you will go also with an unrelated donor or even an haploidentical donor? What will be the choice at your center? Thank you.
Thank you. How old is he? Sorry.
8-year-old.
18-year-old.
8. Is a pediatric
sorry.
patient. Yes,
Sorry.
I'm a pediatric hematologist. Sorry.
So yeah, it's in the the middle of the issue for this patient, because the quality of life looked like to be very impaired for this patient, especially with all the bleedings. And even if he didn't present severe bleeding, you have to use red blood transfusion. So it's almost a severe bleeding. I think that we consider some of our patients with severe bleeding when they needed to receive a red transfusion. So if it was my patient, we don't have a clear recommendation about that. If it was my patient, I think I will be in favor of a definitive therapy in this patient due to the impairment of the quality of life. But it's a discussion with the family, because you say that the family were waiting for the gene therapy. But yeah, the question is the family ready to achieve another kind of definitive therapy? I think that in this case, if the family is ready, I will be able to propose transplantation for this patient because of the risk of bleeding and the impairment of quality of life. So I think that it's possible. The results are really good in terms of survival. Of course, there is some complication, possibly some complication that are lower in case of a sibling transplant, but I think that it's not that there are no sibling donor, or maybe we didn't search it for now.
No, he does not have any sibling.
Okay.
But the fact that he has a laboratoristic profile of immunodeficiency with absent IgM, that does not predict the possibility of further complication further along, or it's just, it can stay just like that for years?
It can stay like that. I guess a lot of our patients have very low IgM, but without further complication. But you know that then with age, they can have lower B cell activity. That's possible, but that's not because it's low now that it will be very, very worst later from my point of view. So my choose won't be on the immunological defect, but more on the symptoms and the bleeding, I think. But yeah, I think it could, it won't be a fault to propose a definitive treatment as transplantation in this family. It has to be discussed.
Yeah, we have discussed it. It's just that they are quite against it due to the risks involved. So we don't know how strong to push, because in certain condition we are ready to push to go forward, like sickle cell diseases or other immunodeficiency. In this situation, we're not sure how strong we should push the family. Not push, but
yeah, I think that I totally understand what you mean. With what you said, I think that you can't really push them because we don't have enough strong information today on this patient, and if the family isn't ready to go through all the process of the transplantation, you can't really push them with the symptoms. I think it's my.
I just wanted to know that it was the same approach, even not outside my center. Thank you. Very, very helpful. Very great talk. Very clear.
Thank you.
Thank you. So thank you very much to all of you for having been here for this so dynamic and interactive Q&A session. And most of all, thank you very much, Dr. Mallebranche, for sharing all of your expertise with us. We really appreciate your sharing of time. Thank you very much.
Thank you.
Bye-bye.